Let us start.
Yes.
Divu?
Yeah.
We'll start. So, warm good morning to all. Respected State Secretary Dr. Divu, our eminent faculty, esteemed faculty Dr. Ajay Logani sir, our CDE Chairman, Dr. Faisal Silpi, and our technical assistant, Dr. Unikrishan, other office bearers and dear friends. Today, the third webinar of IDA Kerala State with the most eminent faculty, Dr. Ajay Logani sir. Hearty welcome to you, sir, from the land of God's own country.
Yes, please. Thank you.
So, as the novel coronavirus reached the world, we dentists are also in an anxiety and fear. So the nation is also in a lockdown today, 40th day of our lockdown. This is a deadly potential virus that affects almost all the areas of our life. We salute our frontline warriors of health workers in this fight against this deadly demon. Now, we dentists are acquiring knowledge through webinars in and hibernating stage. So the corona pandemic episode and the post-corona era, the dental treatment scenario should change. It has to be changed. We need a behavioral and structural change in our practice. Now we are facing a global health crisis. So this corona virus is abundantly present in our nasopharyngeal and the salivary secretions of affected persons. So as a dental healthcare professionals, we act very intelligently, not only to provide care, but also to prevent any nosocomial spread of infections also. So, IDA Kerala State is released a COVID-19 guidelines and consent forms yesterday. So, I think all the members have got it. So, please go through these guidelines and please practice a better and safe, prudent dental practice, restricted practice now onwards. That is the only thing I want to tell you. So we all know our very eminent faculty from AIIMS. So we'll talk about management of endodontic emergencies. So we are all ready to hear from you, sir, the management of endodontic emergencies. And I'm happy to start this program, inaugurate this program, and we are ready to hear from you, sir. Thank you. Stay home, stay safe, and stay inspired with this Logani, sir. Thank you.
Thank you.
Dr. Divu, please. Good morning, everyone. At the outset, I should thank Dr. Ajay Logani for taking the time to speak to all the members of IDA Kerala State. Thank Dr. Faisal for bringing this eminent faculty for the benefit of our members. The photographs which sir has put on the screen, when we were talking before, it was taken from Kannur beach, a beautiful sunset, and I hope that the sun will set on this virus too in the coming days. We, IDA Kerala State has brought out a comprehensive guidelines, and it has been released as the President mentioned, and it is available on, it will be shortly available on our website, can be downloaded. In this section, in the guidelines, at the end of it, there's a Malayalam section. That's for the dental auxiliaries, staff members. So you can take a printout and give it to them, and it will be put on, it can be useful for them also. These are difficult times, and lockdown is coming to an end. The perspective of dentistry has changed. And I request all of you to practice. When you practice, ensure that you're safe and you stay safe. And we can gather a lot of wisdom from what Dr. Ajay is going to tell us. And wishing you all a happy learning curve. Thank you. Wishing you all the best.
Respected President of IDA Kerala State, Dr. Joseph CC, Secretary, Dr. Deepu, Technical Team Head, Dr. Unikrishnan, and my dear Dr. Ajay Logani. It's a matter of pride and privilege to introduce my batchmate and my roommate, Dr. Ajay Logani, for the Kerala State IDA CDE webinar program. We did our PG in Annamalai University from the year 1989. And after that, Dr. Ajay Logani has done PG in Conservative Dentistry and Endodontics from Savitha University, Chennai. Since then, he is working in All India Institute of Medical Sciences, and now he is the professor and head of Department of Endodontics, All India Institute of Medical Sciences. He's also the president. He's also the president of Indian Society of Dental Traumatology. There are lots to talk about him, but I welcome Dr. Ajay Logani for this webinar of Kerala State IDA. And over to you, Dr. Ajay Logani.
Yes, thank you. Thank you very much for the kind introduction. Respected President of the IDA Kerala, Dr. Joseph, Dr. Deepu, State Secretary, the Technical Assistant, Dr. Unikrishnan, who's been very kind for having taken yesterday another kind of a dry run. My dear friend Faisal, thank you very much for having invited me for delivering this webinar today. First, congratulations to Kerala. I just heard Kerala as a state has been in the front line for taking all the measures, the right measures against COVID-19, and the entire country had to learn something from the management skills of Kerala and Kerala people. So real good work which has been done there, and I do understand that the IDA Kerala has also been for the dentist, with the dentist during these times, and they've taken out guidelines, and I would also go through those guidelines because I'm sure the guidelines being made under your guidance have been extremely useful. I would be starting my presentation. Sir told that these photographs were taken in Kannur in February when I was there for an official meeting, and Faisal told me that time maybe May or June we would be getting back, but I didn't realize that the things would change so fast that we would not be able to make back to Kerala so soon. Yes, I proudly represent my institute, which is the All India Institute of Medical Sciences, where I work at the Center for Dental Education and Research as a professor at the Department of Conservative Dentistry and Endodontics. It is the hashtag word Corona for the last couple of days, right? When I heard this word, it was 10 years back. The first time when I heard the word Corona, it was 10 years back, and it was imported. And that was a beer that time. And it changed everything. Everybody, I can see the smile on Deepu's face, everybody who tasted this beer realized that we were not having the right beer in this country. And it changed the way the beer drinkers thought about beers in this country. And everybody started to enjoy this Mexican beer. The last time, or the most recent time when I heard about this word Corona, again, it was imported. And this time it turned out to be a virus. And this virus changed everything. Believe me, it has changed everything. The way we stand, the way we shop, and obviously the way we conduct our dentistry. This is how the right side of the picture is showing how we have been doing all the emergency cases at the dental center. Previously, just 3 months back, doctor's coat was sufficient, but within 3 months, this is how we've been practicing endodontics at our department. And not only the way the clinical dentistry has changed, the way we are taking our classes have also changed. Previously, seminars were there good for us but it is all about webinars now. Long distance learning. Annamalai was famous for long distance learning, and I've never ever realized how could you learn long distance. Now do I realize that long distance learning is going to be the future and maybe the most beneficial way. As I was telling Pfizer, the biggest advantage, you're always on time, maybe a couple of minutes here and there, but a dedicated crowd. And I'm thankful for everybody who's joined this webinar on a Sunday at 11:30. Very kind of you to be here and listening to me. All right. You do realize maybe a government hospital or any kind of a private practice, we always had timings in dentistry. We would have a pre-lunch timing and we would have a post-lunch timing, and the afternoon siestas were there for most of the dentists. And a lot of people joined dentistry for this reason, because they thought that everything in dentistry was planned and scheduled. Everything, right from your patients, right from your work, everything could be planned, not in hours, but days in advance, that this is the patient you could go, because more or less everything was there to be planned and done. And as far as the emergencies were, absolutely rare. As far as endodontic emergencies were, they were considered as rare, but they do occur. We have to understand that endodontic emergencies do occur. They can come in any shape and form. They could be from a swelling to a dental trauma to an irreversible pulpitis, pain. Anything related with pain is an endodontic emergency. And you would realize among all the branches of dentistry, barring oral maxillofacial surgery, it is endodontics which is in the front line, and pediatric dentists who are in the front line as far as pain management and emergency is concerned. That is the topic which I thought would be appropriate to be taken during this time, the management of endodontic emergencies, because according to most of the guidelines, it is the endodontic emergencies which we are supposed to cater to our patients, and all other elective procedures can be postponed for the time being. Before we go any forward, I just need to tell you that every slide has a message. All right, this presentation has been made from a point of view for postgraduate, from a point of view from an undergraduate and dental practitioners, keeping them in mind. So please, I would take my time. Faisal has said that I have almost 60 to 65 minutes to speak, so I'm going to take my time, but there is a message in every slide, and I would like you to take that message very well. You have to understand that there is a difference between emergency and urgency. It may be an emergency for a patient, but it may not be an urgency for the endodontist. So you must recognize what is an emergency, specifically during these times where the reaching of the patient to you is difficult, for you to manage the patient is difficult. So always have this distinction in your mind clear. What is an emergency? What is an urgency? How do you differentiate between them? You have to ask them 3 key questions. Now, this can be done over phone. So that is what we understand of a triage, specifically during this time, that ask your patient these 3 key questions to know whether it is an emergency or an urgency. How long has this pain bothered you? If he says it has been there for the last 1 week, all right, versus another patient saying, doctor, it's been there for the last 24 to 48 hours. The second question is, does your pain disturb your sleep? Are you getting up because of the pain in the night? And have the over-the-counter analgesics relieved the pain? If the patient has been taken
looks like Logani sir has lost his connection. Please hold on, he will be reconnecting shortly.
as a dentist or a specialist during these times, you need to differentiate between urgency and emergency. If the patient is having pain for 24 to 48 hours with high intensity, if it is not getting relief with the over-the-counter analgesics, and if he's getting up with the pain in the night, then it is a true emergency, and you need to see the patient immediately. An emergency demands ethically and legally that the patient is having severe pain and he has to be accommodated as an unscheduled clinic visit. Compared to this, as far as urgency is concerned, when the patient says the pain has been there for a week, and if I take a Combiflam tablet, that is an ibugesic, my pain gets relief for 8 to 10 hours, and I'm having a comfortable sleep, you can tell him that to continue with his analgesics and maybe see him as a scheduled visit. So I hope and pray that I'm clear as far as an emergency and an urgency is concerned based on the patient's symptoms and signs. Once you've decided that that there is an emergency, we must recognize that there are three types of emergencies which I'm going to be talking during this course of my webinar. The emergencies which the patient comes in, those are usually the pain because of a tooth or because of the trauma. Emergencies which can occur intraoperative, which is because of us, and emergencies which can occur after you have completed the treatment, that is a post-operative emergency. So this slide tells us that the emergency could be a preoperative emergency, which is, as I said, because of the pain and swelling which the patient's diseased tooth is giving, or an intraoperative or a post-operative emergency, which is usually iatrogenic, as you would see as the slides go on. As far as just these 4 slides, I thought I should add during the special considerations. If you are now decided that this is an emergency and the patient is coming into you as to your clinic for treatment, these are certain things which have come out from our Indian Endodontic Society, and I'm sure as Dr. Joseph said, that they have taken out it for Kerala IDA also, but this has become almost like a norm now, that you must take a disclosure and a screening consent form. The questions are very specific in this form. The patient should not have had a foreign travel. The patient should not have had a history of cough and cold, should not have come in contact with an active COVID patient. Frankly, you're really looking at every patient at this stage as a susceptible COVID patient. So these consent forms are necessary to safeguard ourselves as far as the patient also. Few precautions which have been mentioned by our society is that please wear mask. The government of India yesterday took out a direction that anybody coming to the hospital has to come with a mask. And if the patient has come to the hospital or your clinic without a mask, it is mandatory that you are going to be providing the mask to the patient. So that is a very clear guideline which is given by the Central Health Ministry, that the patient should come in wearing a mask. If they're not, then you should provide a mask. The old tradition of South India, I've seen it in Tamil Nadu, I've seen it in Kerala, it is coming back. Remove your shoes. They're a source of infection. An article from China told us that the virus can survive in your footwear for almost 24 to 48 hours or longer. Remove your footwear outside and come in. We guys have been doing it. Believe me, the South India is leading in a lot of tradition which are going to be a norm post COVID-19 pandemic. And we're very, very happy to be following that. You would need to. Yesterday, I did a YouTube where the question was, would there be an increase in the cost or in the investment of the dental clinics? Yes, there is going to be some investment cost. The first investment which you must do is a digital thermometer, a non-contact thermometer. That would be the first barrier for screening. Any patient reporting with fever, I think we must not be treating that patient at that stage. Maybe we can take care of his pain with some other modality, but must tell the patient that it is for his and the community safety that treatment should be postponed. Barrier is something which is necessary. This is one of our own doctors, and this is how we are treating. The only thing which I needed to, I'm sure the IDA Kerala has already told you about everything which is required. The only thing which I need to highlight here is that we've come down to the conclusion, and our government is also saying that the face shield is the most important thing for us. So guys, if you are working without a face shield, if you're just concentrating on an N95 and a goggle, please, if you have to compare goggle versus a face shield, go for a face shield. For a simple reason, goggles, I don't know how many of you worked with it, they cause fogging, claustrophobia, and you cannot work with magnification. All those issues are there. So my only thing is N95s, everything is there. I'm sure you guys already know about it. From my side, for my doctors, it is a face shield, which I am insisting and asking them to be wearing every time we are taking an emergency case. Okay, coming back, we just deviated specifically for the COVID-19 time period. I told you that the emergencies could be preoperative, intra, and postoperative. The next 30 slides are on preoperative emergencies. And the first thing which you need to do for such patients is reassurance. Specifically during this time, they have been distraught with pain. They don't know what to do, where to go, how to go. I had a neighbor who had pain. She said she does not even have a driver to drive her to the hospital. So people who are having the privileges previously have been suddenly been deprived of these privileges. So they're distraught with those things also. And obviously the pain is causing them a hell of a lot of concern. And they're cursing everything, that why everything had to be there at this stage. And so reassurance, just a word of reassurance that we are there to help them is more than enough. I would just like to, this is an acronym for the emergency management of a patient. That is the 3 Ds. And the first D is a definite diagnosis. And the diagnosis comes from the case history. Just give the patient a patient's hearing. That's it. Just hear him out. Just read what I have written. I'm not going to go through the detail. Just give him a patient's hearing. He will be telling you the diagnosis. If he says that the patient is, for the past 24 hours, is having pain, is not being relieved by any OTC, it is made him wake up in the night, it is an emergency, and most probably all the tests which you would do would either be positive, and the pain on percussion is there, most probably you are, and if there is nothing on the radiographs, you are dealing with a symptomatic irreversible pulpitis. In endodontics, there are only 2 diagnoses which are true emergencies. One is symptomatic irreversible pulpitis with or without apical periodontitis. I presume that everybody would be able to make the understanding out of that, that when I say there are only 2 emergencies in endodontics, is at per se the tooth, irreversible pulpitis with or without apical periodontitis. That is, he has severe pain with pain on percussion or no pain on percussion, but he has severe pain. That is what I mean by symptomatic irreversible pulpitis with or without apical periodontitis in simple terms. And this is a true emergency. Once you made the diagnosis, the second thing is definite treatment. Irreversible pulpitis cases are very difficult teeth for anesthetizing. They're called the hot mandibular teeth, not because they are good looking, it's just that because they are extremely difficult to anesthetize. So basically, the anesthesia, as I said, is a challenge. The challenge is because of 2 reasons. One is an emotional component. I told you the patient is already distraught with pain. So that is also known to play a role in the efficacy of anesthesia. And obviously we have a physiological reason because of the inflammation in that area. If it is a mandibular molar or if it is a maxillary molar, inflammation in that area reduces the efficacy of the local anesthesia because of the acidic pH, and the dissociation quotient of the local anesthesia is low. So the local anesthesia definitely it has a lower efficacy in such cases. So both the factors combined, the emotional component and the pathophysiological component, leads to a decreased efficacy of a local anesthesia in hot mandibular teeth, and it is definitely a challenge for for even the most experienced patient. So how do you improve the success of this local anesthesia? Obviously, you've got to give the best block. You've got to be making sure that the block is perfect. Now, I presume that our local anesthetic block is presuming still, how can we improve the efficacy of that block after having given a perfect block is by something which I say verbal anesthesia. These are all ways of just comforting the patient, of reassuring the patient that we are going to be relieving of his pain. And believe me, out of my own experience, these all things work. In addition to the local anesthesia which you use, something like verbal anesthesia is going to make the patient very, very comfortable. You've got to make sure that he is relaxed in your dental chair. He has confidence on you, and then only would his pain quotient be low, and then only would he be able to get the dental treatment or the endodontic treatment specifically done as far as the treatment is. Always try and achieve pulpal anesthesia. Guys, this is what I need to tell you. When you give an inferior alveolar nerve block, there is something called as a soft tissue anesthesia. That is, we ask a patient, is your tongue, tip of the tongue numb? We ask the patient, is the half of the lip numb? Now that is soft tissue anesthesia. That comes usually between 5 to 7 minutes. But pulpal anesthesia in such take 15 minutes. So try and differentiate between soft tissue anesthesia and pulpal anesthesia in a hot mandibular tooth after an inferior alveolar nerve block. The soft tissue anesthesia is checked by those physical sign of symptoms or subjective sign of symptoms of the lip getting numb, the tip of the tongue getting numb, but the pulpal anesthesia is only achieved after 15 minutes. And objectively, it is known by if the EPT test, that's the electric pulse test, comes negative. That is, you put your EPT, you put your electric pulse tester, go down to the highest numerical value, which is sometimes 60 or 80, depending on which EPT you're using. And if that, after putting that, the patient says he feels no sensation, then are you dealing with pulpal anesthesia? The practical message out of this slide, an important message, is that if you are dealing with an irreversible pulpitis, you give an inferior alveolar nerve block by the clock, wait for 15 minutes. No harm going up to 17 minutes. During that time, cover it up with your verbal anesthesia and your work is done. All right, so these are two things. Give your perfect nerve block, use your verbal anesthesia, wait for 15 minutes for the pulpal anesthesia, and then there are drugs which can help you. So again, as I said, I have a message for every slide. I tried taking out the best articles which are in the endodontic literature as far as that particular thing is concerned. As far as the efficacy of oral medication, they say that either of these medication or a combination of these medication given 1 hour prior before starting this medication is definitely increasing the anesthetic success. So either a dexamethasone, 5 milligram of dexamethasone as an oral, or any ibugesic. So ibugesic, that is 600 milligrams of brufen, is effective if you give it 1 hour prior to before you're attempting your endodontic treatment. If you're really looking at details of the efficacy of pre-anesthetic medications, maybe this is the highest level of evidence, a systematic review and a network meta-analysis, which in a pyramid of evidence is considered to be the highest. The message here is that yes, you can give a pre-medication of either a dexamethasone or an ibuprofen. Tramadol is also effective if you give 1 hour before your inferior alveolar nerve block. It is known to improve the efficacy as far as endodontic treatment is concerned. Supplemental injections, I've already told you the 3 or 4 methods of improving your inferior alveolar nerve block, because why am I insisting? Once your nerve block is effective, 75%, 80% of the battle is won. You've got to have your nerve block perfect, then only the patient would be perfect. So I have already given you tips that how could you improve your efficacy. As far as supplemental injections, we know that theoretically we have intraligamentary, we have intraosseous, we have intrapulpal. Intraosseous requires a specific machine, which I'm not sure everybody does have it. Intraligamentary can be painful, and it is known to cause periodontal ligament necrosis after the injection is given. Intrapulpal, if you want your patient to jump out of the chair, try give an intrapulpal. Not only the patient jumps out of his chair, his confidence on you goes down very well, and you were very less, and you would notice that he would be very, very fidgety during the treatment. He would keep moving. He would ask you to stop the treatment 15, 20 times in between. The confidence level of the patient goes down with all these supplemental injection techniques. Theoretically, they may seem to be working, but as far as clinical is concerned, please avoid them. And I would like to add here, the oral surgeon colleagues, if they are here, they would agree that if your inferior alveolar nerve block is perfect, even a 0.5 ml injection solution, waiting for 15 minutes for the pulpal anesthesia, 99% of the hot mandibular, so-called hot mandibular teeth would be managed very, very successfully. You've got to make sure that they are as comfortable as Pink Floyd told us when we were students. And I'm sure each one of these colleagues of mine in the 80s heard this song in the hostel comfortably now. That is what we mean. Once you've made the patient local anesthesia is effective, we've got to start our treatment. And that is what is the important thing also. Now, we are talking about emergency, all right? And the type of treatment which you would give in an emergency depends upon the time. If you are really looking at, so not in COVID days, but if in a routine thing, if you are really looking at squeezing, so you are full, your day is full, and the patient comes in, you say he has an emergency, you prove to yourself, and you have to squeeze between the appointments, then, and that means you have minimal time. So you have a 6 o'clock patient, you finished at 6:30, your next patient is at 6:45, and you are really looking at squeezing this patient for 15 minutes. How is the best method you can relieve the patient of his pain is by just doing complete pulpotomy. That is removal of the pulp in the pulp chamber of a posterior tooth right up to the orifices is the safest, the fastest, and the best way of relieving the pain of a patient. Give the local anesthesia, make the patient wait for 15 minutes, open the pulp chamber, take out the pulp of the pulp chamber, don't do anything, and your patient is relieved of his pain, and he is your patient for life. As far as after the pulpotomy procedure, which you can do in 20 minutes, you got to dispose of the patient. You've got to understand that putting a Pharmacological or a eugenol pack and sending the patient. One thing here, you not to leave the tooth open under any circumstances. You've got to close the tooth. But as far as these medications are concerned, of putting Pharmacological there, putting eugenol there, there is a way back article which is in the 80s tell us very clearly that only a sterile cotton pellet and a temporary filling is sufficient. You really do not need to put any medicament-laden cotton as a temporary restorative till your next visit. So please, guys, avoid it. Pharmacological, which we get nowadays, does not have the original Buckley's formula, so it is not effective. Sometimes it just leaches out of your temporary filling, giving a very bad taste. The same thing, the eugenol which we are getting is not the same clove oil which could relieve there is no indication of giving a cotton laden with any medicament, except sometimes we've seen that it gives rise to a little bit pain, because these also can act as an inflammatory initiator on an already inflamed pulp. So this is a big cross if you are really looking at giving it as a medication. The biggest cross is this, Kostanov. Guys, I am made to understand over years that this is something which a lot of practitioners, a lot of clinicians prefer between 2 appointments, specifically if you are unable to clean the entire. That means if you are not able to do a pulpectomy, that is entire removal of the pulp tissue, a lot of times these guys give this. It was with arsenic, without arsenic. This, if you give it in an irreversible pulpitis cases where you've done a pulpotomy, the patient is born to sue you because of the increase in pain which would occur over the next 24 to 48 hours. So if it was a smaller cross for the eugenol or the formaldehyde dressing, it is a huge cross. Please guys, maybe the companies will come and tell you that this would just mummify the pulp. It will help you to, the next sitting would not require local anesthesia, but please do not give it in irreversible pulpitis cases. Definitely not in pulp necrosis cases. It is going to be a huge problem for the patient and you as far as the pain is concerned. So if you had less time, I told you, pulpotomy is the solution with no cotton with any kind of a medicament. Give a closed dressing and call the patient again. I would tell you which is the right time period. But if you have moderate pain, like I said, you have 15 minutes at that time, you have 30 minutes at this time, then what you do is partial pulpectomy. What do you mean by partial pulpectomy is the largest canal. So for a mandibular tooth, it is the distal canal. For a maxillary tooth, it is a palatal canal. So if you have sufficient time, just after the pulpotomy, that is the removal of the coronal pulp, remove the pulp tissue from the largest canal, the distal of the mandibular, the palatal of the maxillary, and that is what would be partial pulpectomy. That is if you have sufficient time, that is moderate amount of time is what you are looking at. If you have sufficient time, by good luck, your original appointed patient did not come, you have the indication for a single shot endodontics. That is, you can complete the root canal in a single sitting. No flares up are expected in irreversible pulpitis with or without apical periodontitis. It is an indication for a single sitting root canal. If you have the armamentarium, if you have the expertise, if you have the time, there is no problem. This would be the best way of relieving the patient of his complete pain, and he would be the most thankful because he would not need to come again, specifically in the time period of COVID, where you would ultimately be looking at reducing the number of visits. So it is an indication for a single sitting root canal. As far as evidence suggests, again, a landmark article, Assessment of Alternative Emergency Treatment for Symptomatic Irreversible Pulpitis, it clearly says that pulpotomy is the preferred method. It is not that time consuming, it is not that technique sensitive, and it relieves the pain as good as partial pulpectomy or complete pulpectomy. So at least I think, guys, we are on the same page, and hopefully we are with each other and understanding what I'm trying to give the message, that in irreversible pulpitis cases as an emergency, pulpotomy may be the option if you can manage that. But obviously, if you have the sufficient time, COVID area, you are really looking at finishing it. Cardinal rule, I'll try and explain it to you. I'll just try and explain it to you. Cardinal rule in managing emergency cases of irreversible pulpitis. If you touch, that means if you have even touched the 3 orifices, that you've touched partially the distal, the mesial, and the mesiolingual and the mandibular molar, complete the pulpectomy, guys. If you have, because your very fact of instrumentation, bare minimal instrumentation in the, even in the first 1 or 2 millimeters of the canal, increases the inflammatory response and increases the pain quotient. So if you touch, completely do the pulpectomy. And if you do not have the time to do the complete pulpectomy, then guys, just do a pulpotomy. That's the cardinal rule which I want to explain. If you touch, spend the next 1 hour, 30 minutes, complete the pulpectomy. If you don't think you have the time or the armamentarium or the expertise at that particular time, just do the pulpotomy, give a non-sedated or just a sterile cotton pellet, close it, and call the patient again. As far as occlusal reduction is concerned, yes, occlusal reduction is to be done in specifically in teeth with symptomatic irreversible pulpitis with symptomatic apical periodontitis. That means that the patient, which when you percuss with the back of your handle mirror, there is pain. In those cases, you must do the occlusal reduction. But the literature tells us that the experience of pain, so the patient decrease in pain would only occur over a period of 12 hours. But this maybe because of so I told you that the occlusal reduction needs to be done in cases where the tooth was tended to percussion before you started the treatment, and both the cusp, the functional and the non-functional cusp, both have to be reduced till they are out of occlusion. That is how you would like to do your occlusal reduction in these cases. So we finished with the 2 Ds. Yeah, I hope you remember what was the first D. The first D was a definite diagnosis, that it is an emergency. The second was definite treatment, which started with local anesthesia and how to enhance the local anesthesia efficacy and what to do as an emergency treatment. I gave you the message that pulpotomy would be sufficient. Pulpectomy would be the best if you have the expertise and the time to do it. The third D is drugs, guys. This is something, again, very, very important. Just read the screen, which will show you few sentences which are extremely important. I'm going to be talking about analgesics as well as antibiotics. As far as the analgesics is concerned, again, you would see I have got all the systematic reviews, which is the highest evidence, which is to be there for the scientific people to see. It says that the best medication is a combination of 200 or maybe 400 ibuprofen and acetaminophen 500. A combiflam tablet, guys. Don't go to codeine, don't go to ketoprols. The evidence tells us that the best medication to relieve even the most severe pain is just your simple combiflam, which is a combination of ibuprofen and paracetamol or acetaminophen, and that is the choice based on evidence, and that is the choice based on our experience that combiflam can relieve the pain. The only thing is, guys, don't give it as an SOS. It has to be given as a around the clock, in the sense that has to be given as a regimen, like you give antibiotics. So I'll try and explain. If you say take your analgesic at 12 o'clock, don't tell your patient that take it when it pains again. You know that depending on the severity of the pain, the efficacy of this combiflam would be for 6 to 8 hours. Tell your patient that you've got to repeat the painkiller at 6 o'clock in the evening. That is 6 hours from now. So that it has to be given that way for at least 3 days. So it is the same way like you give your antibiotics. Kindly ask your patient to take your analgesics also the same way. Do not have it as an SOS method. You have to tell them that maybe if it is 2 times a day, then let it be 2 times a day, but ask them to take it at least for 72 hours. That's what the evidence tells us. As far as antibiotics are concerned, again, systematic review, read it. What does it say? No evidence to support the use of antibiotic for pain relief in irreversible pulpitis. I'm repeating it. No evidence to support that the use of antibiotics for pain relief in irreversible pulpitis. no evidence for relief of pain. No evidence that says that the antibiotics is going to improve the efficacy of local anesthesia. So antibiotics, as far as irreversible pulpitis is concerned, has no evidence whether it is going to relieve you of your pain. It has no evidence that it says it is going to improve the efficacy of local anesthesia. The only evidence which we have is that it is going to do this, antibiotic resistance. Look where India is. I think this is a 2015 data. I'm sure 5 years this data has changed, and take my word, colleagues, that the dentists are contributing, if not solely, but at least a lot of percentage of dentists is contributing to this chart of resistance. So what only thing we are doing is that when our patients would actually require antibiotics for some serious ailment, they may be resistant to it because of our prescribing the antibiotics for cases like irreversible pulpitis. So my message is very clear: analgesics, no SOS, around the clock. Antibiotics, no indication. They're only just getting them resistance, and maybe we're not going. If you've done a pulpotomy, call your patient between 24 to 48 hours, because that's the time period where the patient would be pain-free. That's the time when he's taking the analgesics. If you delay the treatment anything more than that, the patient is going to experience maybe pain again. So if you've done pulpotomy, 24 to 48 hours is a good time to call your patient back, complete the root canal treatment. If you've done pulpectomy, you can call the patient and just ask. Calling patients is actually a good habit. We built it over years. Even in the government sector, we've had that habit. My colleagues call up their patients, and that just instills confidence in them. Please do not think in another way that the patient may think that, why is the doctor calling? It is being appreciated that call your patients and ask how they feel. So anyway, call them to complete the treatment, or call them to ask them how do they feel. The second emergency, the first emergency in endodontics is irreversible pulpitis. Another emergency is an acute apical abscess, which is pulp necrosis. And that is also something which I must tell you how to deal it. Obviously, these are pus-filled cavities. You've got to relieve the pressure. You've got to do an immediate access opening to establish drainage. Messages are very clear, as I said, on every slide. So if you get a case like this, where there is an acute apical abscess, as soon as you open the canal, there is pus drainage. Please do not use sodium hypochlorite as your first irrigant. Sodium hypochlorite, what it does is it clumps the pus cells, and those pus cells accumulate at the apical end, stop the drainage occurring, which was free flowing previously, and the patient does not get relief of his pain. So if you have pus coming out, please do not use sodium hypochlorite as the first irrigant. What do you use? Just normal saline. I use distilled water. Normal saline, also try putting a drop in your mouth. You would know what the taste is. Just triple distilled water, warm it, and irrigate it copiously. When I say copiously, 5 ml syringe, at least 5 to 10 times. So 50 ml of warm saline or distilled water should be done in such cases as the first irrigant till the pus drainage does not stop. Keep irrigating with a warm irrigation solution, maybe saline or distilled water. Once the drainage stops, so you've irrigated it is 50 ml plus 5 ml syringes at least 10 times, irrigated, nothing else. Once the drainage stops, complete the biomechanical preparation, guys. As I told you, in irreversible pulpitis, you had the option of just doing pulpotomy and sending the patient. In these kind of cases, if you do not complete the biomechanical preparation within the next 24 to 48 hours, with or without antibiotics, the patient is going to come back, and he's going to come back with the swelling. So you've got to complete the biomechanical preparation in these cases. Give a calcium hydroxide. Just mix your calcium hydroxide with distilled water slurry, place it in the canal with a lenterospiral, and close it. Never, ever leave the pulp chamber open under any circumstances. Clinically, Practically, theoretically, it has been proven that there is no added advantage of leaving these teeth open. You've got to complete the debridement, give a calcium hydroxide, and just close it. Just close it. As far as antibiotics, you really do not need to give in every case, but yes, in such cases, there are indications for giving antibiotics, specifically if the patient is having fever because of this abscess, if there is lymphadenopathy, and if the infection is spreading. If you feel it is already gone in for a cellulitis, like in this particular photograph, if you think that is the way it is going, yes, antibiotic is to be given, and this is the antibiotic, 50 rupees for a whole 5 days course. So not only you should be concentrate towards the cost effectiveness of the drug, the effectiveness is obviously a concentration, just a generic amoxicillin 500 3 times a day for 5 days, add with an anaerobic medication, Metrogyl specifically 400. They say 3 times a day. For us, 2 times a day is good enough. Orally is going to be helpful. There is a lot of discussion as far as antibiotics is concerned, but constraint of time would not let me go through it. But just keep in mind that when to give an antibiotic, and if you need to give an antibiotic, which is the antibiotic which is needed. Amoxicillin with Metrogyl. Specific post-operative instruction, no hot fermentation or cold fermentations from outside in abscess cases. The only thing which you need to do is warm water holes, not rinses. Ask the patient to just get the warm water there in his mouth and hold it in that area of swelling. That is what is going to help. But please ask him not to sleep on that side, not to keep anything hot for extraoral fermentation initially, or any cold fermentation. It is not going to help the patient. Incision and drainage in these cases is again extremely case specific. We had a discussion in our department a couple of days back. I told them that the swelling itself tells you I'm ready for an IND. In the first 2 cases, you do an IND, you're just going to give the patient pain, and if you do it extraorally, then you're going to give him a scar and nothing is going to be achieved, because in cellulitis cases or which is a diffuse swelling, you're really not looking at any advantage from an endodontic point of view, because I do not see any pus drainage being established. But yes, if you have a teasing abscess, which is already pointing, the abscess itself tells you, guys, just stab me and I would be relieved, and the patient would be relieved. So again, very, very specific cases as far as it is concerned. Obviously, you're really looking at recalling the patient and completing the root canal in the second setting itself. You need to call the patient within 3 to 4 days. You had to complete the biomechanical preparation. You did a calcium hydroxide. On most of the cases, your patient would be asymptomatic. If in case the swelling still persists, which does in a lot of cases, give in the second setting, just open, copiously irrigate, give another calcium hydroxide dressing, send the patient, but call him within 3 to 5 days, because calcium hydroxide's efficacy goes down after the 3rd or the 5th day. Refer if required. Specialists are there, oral surgeons are there, our colleagues are there, specifically if you're looking at an IND, if you think, always do everything in the benefit of the patient. I always say sometimes heroic endodontics, heroic procedures should be avoided. Let your colleagues take care of it. Refer. When I say refer, it could be just a telephonic refer. There is no harm in asking that what could be. Another true emergency is, guys, get this, if it's the offending tooth, everything seems normal. The patient tells us, I'm having severe pain. I'm having severe pain. Nothing can be diagnosed. Most of the time, this is like cracked tooth. Yesterday, we had a tooth which had a vertical root fracture. You can't diagnose anything. Everything is normal. The clinical examination is normal. The x-rays are normal. And your signs and symptoms, your clinical tests are all normal. You're just scratching your head. The only thing you need to do is reassure the patient, give him analgesics, wait for 48 to 72 hours, and ask the patient specifically, go back home and see which tooth hurts you. Most of the times, in cracked tooth is a specific situation. The inflammation spreads from the tooth to the periradicular tissues, and the tooth becomes tender to percussion within 48 to 72 hours of you seeing the patient. Just reassure, just giving over the counter analgesics, tell the patient to observe which tooth is giving you pain. The patient comes back and tells you which tooth is the pain is coming from. And it is always better to wait than sorry and treating the wrong tooth. So specifically in teeth where you cannot diagnose, I said cracked tooth is a it is an increased. A lot of cases of cracked tooth are behaving like this. So please guys, if you can't diagnose it, wait and watch or refer again. Another dental trauma is again an emergency where we guys cannot refuse. Emergency intervention of dental trauma is very specific. As I said, I'm only telling about the emergency intervention. If you just do a couple of steps right in the dental trauma management, you've done the whole work. You do the things wrong right now, the case is finished immediately. So just do a couple of things right as far as the dental trauma is concerned. That the first thing is reposition. If it is a fractured root, just with a gentle pressure, just push it back into the socket. If it's a lateral luxation injury, just push it back into the socket. If it is an avulsion case, just reposition back into its socket. So as far as emergency treatment of dental trauma is to get the thing back into position, that is reposition. If you can't give that, if it's an avulsed case, at least give the right instructions to the patient on phone. If it is an avulsed case, just tell him if you can find the tooth or the fragment of the tooth, just get it into the milk to the dental clinic and maybe. So the right information is necessary and the right treatment in the emergency for dental treatment is dental trauma is necessary. That is, the first is repositioning. The second is the right information. And if I may say, the third is stabilization. Just do these two things, reposition and stabilization. The trauma case has been taken care for as far as emergency is concerned. But obviously, I came to Kannur 2 years back and spoke on this. That's rigid splinting is a no-no. You guys don't do this. Please, the oral surgeons, forgive me. No intermaxillary for the periodontal, no composite block between the teeth. These are all considered as rigid splints. The only thing you got to do is simple as that. Just give a flexible splint and dispose of the patient. If you've taken care of, even if you don't do anything at this stage, just reposition and splinting for any type of injury. So even if you are not very well versed about that type of injury, sometimes we also get confused because there are multiple types of injuries coming: dentoalveolar, root fracture, a lateral luxation. No problem. Just reposition and give a flexible splint, refer it to a specialist or read it up, and maybe the case can be taken care of at a later stage. Obviously, the evidence tells us that you've got to call the patient back within 7 to 10 days because we got to initiate the endodontic treatment. Otherwise, sometimes if you delay it, specifically if there are extensive injuries like luxation injuries, within 4 weeks, the root resorption can start. So the cardinal rule is if you've done a trauma case, you've just done the repositioning and splinting, make sure the 7 to 10 days you got the patient back. By that time, the soft tissue swellings have gone down. The patient is feeling better. His other injuries have been taken care of. Now you can concentrate in a definite treatment. So in a dental trauma, it is an emergency treatment. You always tend to delay the definite treatment by 7 to 10 days. When I say always, prefer it. Just don't take my words by verbatim. I have finished with the preoperative. I'm going to take 10-15 minutes for the intraoperative and the postoperative emergencies. As I said, the preoperative is not preventable. The patient had trauma, you couldn't have prevented it. The patient did not care about his diseased tooth, you could not have prevented it. But intraoperative is iatrogenic. This swelling, or once you've done the endodontic, is again something. The patient came in without any problem, but the problem started after which we intervene. So obviously, prevention is better than cure. Prevention is better than cure, made before COVID-19, made before any emergency which can occur in a dental clinic during any emergency procedure. Guys, prevention is better in such cases. The first and I don't know how many of you experienced it. The people who say they didn't experience it, that somebody would have experienced it. The people who say we have never met a person who has experienced this is either lying or have not been practicing dentistry. When you practice dentistry, accidents will happen, will continue to happen, but we need to learn from people's mistakes and be safe. There are two ways of hypochlorite injection, accident rather. You can either inject it into the vestibule or it could extrude beyond the apex. Now, both are extremely unfortunate, specifically the first one, injecting locally in the area, thinking that it was a local anesthesia is a blunder. But it happens, it happens to a lot of people. Recognize it, all right? How do you know that a hypochlorite accident has taken place? If the tooth is anesthetized and you have irrigated with hypochlorite and suddenly the patient says he has pain in spite of the tooth being locally anesthetized, take your word that there has been an extrusion of sodium hypochlorite beyond the apex, and within the next 15 to 20 minutes you start swelling to develop, then again there is a hypochlorite accident because of extrusion. Or if there is sudden bleeding from the tooth, again you are expecting something like a sodium hypochlorite. So the first thing is you need to recognize that a sodium hypochlorite is. So if you're using a sodium hypochlorite as an irrigant, and if suddenly the patient has pain or swelling or bleeding from the canal, please anticipate that a sodium hypochlorite is an accidental injection. You would know it that you've done it. The patient screams. The patient screams, and suddenly everything in that area becomes bluish grayish, and you would know that you've had a wrong injection going in. Management is basically stay calm. Stay calm. Who? You stay calm. Obviously, in such situations, panicking really does not help. All right. So stay calm. That also helps the patient. Inform the patient something like this happened, and inform the patient that we are going to take care of it. So informing the patient legally and ethically is important. Obviously reassuring that, guys, we're going to take care of it. And how do you take care of it is that if it is extreme, if there has been an extrusion, keep irrigating it with normal saline, all the canals or the canal in which there was extrusion, again 50 to 60 ml, that translates into 10-15 times the 5 ml syringe, and give immediate ice packs. Guys, please note it down somewhere, because someday or the other some person will have this. Somebody may give you a call. You must know what to do. After reassuring the patient, start the irrigation with normal saline and give ice packs to your patients. As far as if it is you can give local anesthesia in that area, but if it is already an infiltration or already patient is anesthetized, in spite of that the patient is having pain, should be a lot of people recommend giving antihistamines. I don't know whether there is any role in it, but the literature tells us. But something which I found personally very useful is cover the patient with 5 milligram steroid orally for 7 days, taper it off. It is really helpful in prevention of any other stage of acute hypochlorite accident. So, so management, immediate is ice packs and irrigation. Long-term is antibiotics should be covered, steroids should be given, and the patient should be fine. And really do not need to do anything except, but obviously prevention is something very important. Switch on to cartridge local anesthesias, so that whole problem of injecting with the wrong needle will go off for life. These are safer as far as sterilization is concerned, as far as the efficacy is concerned. It's not very cost enhancing thing. So switch to cartridge anesthesias. They're much, much better. The other two things which we practically tell our postgraduates is either mark them separately or use different cc gauges for irrigation. So local anesthesia with a 2 ml syringe and irrigation always with a 5 ml syringe is always a method of prevention of such things. And as far as extrusion is concerned, obviously never wedge your needle, deep into the apex. Always keep it short of the apex. Always measure, put a stopper onto the needle, so that you are always shorter than. So this stopper is, so if your working length is say is 19, put your stopper at 17 or 17.5. So this way, you will never go to the working length. You would never inject sodium hypochlorite beyond the apex. So these are just few things. I don't know whether this video would, is just saying never wedge your needle, always have a to and fro motion when you are doing endodontic irrigation. And a very good article which says use hypochlorite 1%. Actually, the efficacy of hypochlorite is not concentration dependent. There is more of the solution being fresh, or whether it is a stored solution, even a fresh solution of 3 weeks old of 0.5 concentration is as good as 5%. So guys, for normal use, reduce the concentration, do not wedge your needle, and that problem is going to be solved as far as this is concerned. Again, something, I don't know how many of you have done it, instrument ingestion, instrument going down the throat. Since we work in tertiary care hospitals, we keep having them most often. Obviously, immediate referral with the sample of the instrument. This is something very, very important. You've got, if the patient has had ingested the instrument, make sure that the patient is sent for a chest X-ray and a barium for the stomach. And if the instrument is found, endoscopically, the instrument needs to be taken out. So a gastro colleague has to be consulted. Always send a sample of the instrument, because the gastro colleagues are not used to seeing such instrument. So they should know what they are looking at. This is again one of the cases where the postgraduate had this problem of ingesting an instrument. Tertiary care hospitals are safer. Within 15 minutes, 20 minutes, we were out with this instrument. Obviously, prevention is the thing I told you. For intraoperative and postoperative, it is always the prevention. Rubber dam is okay. You need to have rubber dam, but practically in India, I do realize it is not, but this is how it looks for our postgraduates. You've got to tie everything, specifically if you're working at the posterior part, specifically patients having gag reflex. If you don't have rubber dam, at least this is mandatory. Maybe without this is something very, very difficult. Tissue emphysemas, as I said, I'm trying to cover up all the emergencies, maybe rare emergencies. Again, something which can be recognized, at least recognize as a clinician that you've had a tissue emphysema accident. You are working on a tooth and you are spraying with a 3-way syringe, and suddenly the patient has a swelling, and that swelling has crepitus. Try and do it. It is something like this patient which was there was referred to us from a private clinic. So if you palpate it, you can feel the crepitus, the air bubbles escaping. That's how you describe crepitus. Very, very pathognomonic for an air emphysema. This patient had to be admitted because we could see air on the CT scan, and it can be sometimes very, very dangerous if it goes on to the mediastinal area. But that is something which is very, very life-threatening. Obviously, mild cases, nothing to do. Just tell the patient that, guys, something has gone wrong, and we'll just keep it observation, close the access cavity, stop the treatment, and within 7 to 10 days. But obviously, if the patient starts to have dyspnea, dysphagia, obviously immediate referral is that means that the air is spreading onto the mediastinal area, and maybe you really need to take care of it. Prevention is something which you need to know. Never ever do the drying in this way. Don't point it towards the canal. May it be anything. This were when you were doing the treatment and something went wrong. And I told you about the sodium hypochlorite. I told you about the air emphysema and the patient eating the instrument was the 3 emergencies which can usually happen. Obviously anything else, but these are something which are rarely emergencies. You've got to be able to recognize them well. And post-operative emergencies is that see a scenario of this kind of a patient who comes to you, he's asymptomatic, he just comes for a general checkup, and you say, look, you have a mandibular molar which requires a root canal. You've confirmed the diagnosis that the pulp is necrotic. There is a radiolucency on the X-ray. You say, okay. The patient says, no, I've come from far. You say, I can do it in single sitting. You do the tooth, you finish the root canal. in a single sitting, and the patient goes back happily because everything has been done well. The obturation seems to be well, and the patient goes back. But after 48 hours, what happens is the patient comes back with this swelling. So something which the patient came in just for a checkup, maybe he just came for scaling, he had no problem, no pain, but you told him that, look, you have a bad tooth, you need to get a root canal, I can do it in a single sitting. And this is what the patient comes back for 48 hours. Now, this is something where the patient is really angry, sometimes very distraught again, that look, I didn't have any problem, but what happens when you did root canal treatment? Now, we call these as endodontic flare-ups, okay? These are mid-treatment or post-treatment flare-ups. They are called endodontic flare-ups, or they can be called as endodontic emergencies, post-operative emergencies, and these are, again, something, because we've done it, it is the onus is on us to see the patient immediately. You've got to just understand, why does it happen? Why does it happen? So there are some factors why some things like this happen. You've got to understand that the pulp and the periradicular status. The pulp was necrotic, guys. There was a periapical pathology already present in the tooth where you did a single sitting root canal. Now, such teeth lie like dormant volcanoes. Why I say like dormant volcanoes? The patient was with this tooth for so many years. He was having the cavity, he was having the pathology there, but since his body had adapted, his immunity had adapted, the cavity was probably lying open. There was a balance which was already being established, so he had no pain. And as soon as you did the root canal treatment, in spite of the fact that you took all precautions of asepsis, you took all the precautions of doing the biomechanical very well, what it did was that it changed the microbial balance, all right? So what happens in pulp necrosis and these cases is that the organisms, the microbes are already there. They are living in harmony. The body is in balance, but as soon as we initiate the treatment, the balance is disturbed, and this is one of the major factors. Factor 2 is, so this is something which is not in our hands. We tried our level best to do everything, but that the balance is actually being disturbed, which can cause a treatment problem like this. Obviously, if you go wrong in your working length, if you over instrument, then you have pricked the periapical area. So then obviously there is going to be inflammation, and not only pricked it, you've taken the bacteria from the canal and kind of inoculated there in the periapical region. So you are expecting some kind of pain and swelling to occur. Obviously, if you do the working length short, and considering that you already disturbed the bacteriological microflora there, you're expecting again a flare up to occur. So one is something which is not in the hands, but the treatment does, that it changes the balance between the body and the immunity. And the second is, if we are doing improper working length. Standard of care is apex locators. If you're doing apex locator endo without apex locators, obviously you're going to be more prone to endodontic flare-ups. Factor 3 is incomplete debridement. That again is dependent on whether your working length was right or not. In addition, whether you did the right method or not. In these kind of cases, crown down technique is what is to be preferred. That means first the orifice shaping, then the middle part of the canal, then only touch the intra-orifice, then only reach the apex. This helps us to debride the coronal portion and the middle portion, and less chances of passing on the debris and the bacteria into the periapical, less chances of having a flare. So you've got to do the debridement in the same and then the best method. And obviously size matters. You've got to debride. The apical preparation size should be correct, so that the literature tells us that an ISO size 35 is sufficient for all the irrigations to take place in the apical end. If you have an apical preparation, say 20, then the irrigation which you are doing is not going to reach the apical end, and the debridement and the disinfection is not proper. So if you are really looking at, you have to have an apical preparation size proper. Again, a subject of discussion which is long, but may not be in the preview of this. Obviously, if it is not complete disinfection, you have to infect. You have to use some way of enhancing the disinfection. You must use sodium hypochlorite. You must activate it by some method, maybe manual dynamic, or maybe ultrasonic, or maybe endoactivators, whatever you are using. Obviously, pulp necrosis with asymptomatic apical periodontitis in cases where the patient had no pain, guys, avoid single sitting. The literature tells us that all the methods of chemical disinfection and biomechanical preparation is unable to take care of complete disinfection in a single visit. So it is preferred. It is preferred. See, there is no contraindication, but it is preferred to do these kind of cases in 2 sittings, give an intracanal dressing of calcium hydroxide. You would be much more better. You would have lesser chances of activation of the dormant volcano, as I say, or the flare up. So if you follow these small steps of doing the biomechanical preparation in a crown down technique, doing the apical preparation size to at least 35, getting the irrigation manual dynamics agitation being there, do it in 2 sittings, you will never activate or anger the volcano, and you will never have flare-ups. When I say you'll never have flare-ups, I'm wrong. Maybe you will have minimal flare-ups and the patient satisfaction goes higher. I am obviously, if something like this happens, if there is a post-obturation flare-up, you must recognize it. You should know the reason for it. Obviously, everywhere you see this reassurance slide, emergencies is all about reassuring, and the management of the post-obturation is the same way. If you think that the biomechanical preparation was not complete, if you think that the disinfection was not complete, you will have to take the gutta percha out and a retreatment would need to be done. If you think there is an abscess which is done, then the same way which I described the management of the abscess, you will have to do. So nothing specific, only prevention and recognition in post-operative. Obviously, prevention is what are you really looking at? Take office message. I've been telling everybody, every time we used to take home messages, but these messages are meant for office. Taking home is not going to solve your problem. Just read what I have. It is very, very satisfying and rewarding to successfully manage a distraught patient who has preoperative emergency. In contrast, it is distressing to have a patient with a flare-up after root canal therapy in a previously asymptomatic teeth. So the patient gives you credit whenever you relieve him of pain in the first situation when he comes in with pain or trauma, and if you can help him, he's always going to give you credit. But whenever you create an emergency for him, we're getting a credit. So the whole concept is that we are really looking at to increase the occurrences in the first category and decrease it in the second. That is what at least is my take on this, and this is what I want you to do it. You're really looking at increasing the frequency by which you can manage the patients with pain and decreasing the frequency of the patient where we are giving them pain. And that is what I end with, that I hope this 1 hour, 20 minutes of benefit self, only if you've benefited with this seminar or webinar, sorry, would you benefit your patients. Whenever you would be taking up patients, I hope it has been a fruitful Sunday. And I had to put another photograph here, but Faisal and we all grown old. 30 years photograph, I have one, but I could not. But thank you very much, IDA Kerala. Thank you very much, President Joseph and Secretary Deebu, and my dear friend Faisal, and the technical. We had 3 technical glitches, but we came back. Thank you very much, guys. Thank you. Thank you.
Thank you, Ajay. Thank you, Ajay.
Yes, please. Thank you.
Ajay, you have always been best to tell the best things in a simple way.
Yeah, please. Thank you.
Today's lecture is also the same.
Yeah.
And very informative and a very simple way you have told the important things in endodontics.
Yes,
That's
please.
emergency management in endodontics.
Yes.
There are a lot of questions coming up, Ajay.
Yes, please. I will take it.
I'll read a few of them.
Okay, please.
It's regarding the use of ibuprofen in the COVID period. What is your opinion regarding this?
Yeah, sure. So yes, we did read articles. Perfect. See, questions, I always tell everybody, the intelligence of a person is known by the question he raises, not by the answer he's expecting. So with that background, I would tell you, my knowledge about also is that yes, they did tell us avoid ibugesic in the period of COVID. Yes, very well said. Do I have an answer? Obviously, we're really looking at listening to those guys from the medical point of view. If they are telling us to avoid ibugesics during COVID-19, then yes, we are really looking at an alternate, and the alternates which you do realize are those keterols and maybe keterols, or what else can be given. I think the first medication was Voveron. Voveron may be safer here. Diclofenac, that is diclofenac sodium. So maybe just the alternates to ibugesics would need to be preferred. When I mean to say in routine circumstances, ibugesic would be the most preferred. But during these circumstances, maybe the ibugesic should be not used. Listening to our medical colleagues who may have some evidence. I'm not too sure about that also. What evidence do they have? But at present, yes. Yeah. Something like Voveron or keterol may be preferred.
There's one more question associated with that. Is aceclofenac as good as ibuprofen?
What did you say, Faisal?
Is aceclofenac as good as ibuprofen?
No, it is the combination. So acetaminophen alone would not be as effective.
Hello? I think some technical hitch is there. Yes.
God is really kind. Because you see, the LAN is also going and the Wi-Fi is also going, and again it's come back. So we are happy to be back. Yes, please.
The question was regarding the aceclofenac.
Yeah, I told you that.
Yeah.
Yeah, this it has to be used in a combination, please. Just using this acetaminophen alone may not be the drug of choice for severe dental pain. Maybe mild to moderate dental pain, yes, it can take care of. But as far as severe pain is concerned, no, it would not take care of severe pain, please.
Yeah, next question is about the type of temporary cement advised in preoperative endo emergency after the initial pulpotomy.
Type of temporary
filling.
Yeah. So the only thing is that, as I told you, that never leave the tooth open, and you don't need to put in a cotton which is laden with any kind of medicament. That what I meant with that is sometimes what we do is after a pulpotomy in emergency, we would put formaldehyde or a eugenol, pharmacrisol. You don't need to do it. Just take a sterile cotton pellet, gently pack it into the pulp chamber, and then any type of maybe cavet, which is calcium sulfate, temporary restorative material, or an intermediate restorative material, which is IRM, or any kind of temporary, or even if you're using zinc oxide eugenol based temporary filling material should be given. The only thing is you've got to take care that the thickness of the temporary filling material should be ideal. It should be at least 3 to 4 millimeters, especially in the posterior teeth. Otherwise, again, the leakage takes place, and the infection tends to, and the inflammation tends to take place, please.
Yeah, I've got a question in my WhatsApp from one of my friends.
Mm-hmm.
She's asking about the use of three-way syringe inside the mouth to avoid emphysema.
The use of three-way syringe?
Three-way syringe.
Yeah. So
how to use it?
Not to use it. So
how to use it?
Yeah. So I can show it again. How to use it?
I think the connection got cut during that time, so we missed that.
Yes.
I think. Yeah.
I am sorry. This connection has been.
Okay. It's okay.
Yeah. So this was for the hypochlorite, and yeah. So this is the wrong way. So this is the what you see is the barrel.
So
the steel barrel is.
Ajay sir, you'll have to share your screen.
Screen.
Okay. I haven't done that. Yeah, I'll do that, please. 1 minute. Is it okay now? Do you get my screen?
Yes, sir,
We
we can see your screen.
Can you see my screen now?
Right,
Yes, sir.
right. Yeah.
Yeah. So yeah. So this was what I wanted to tell you is about. So so this barrel, what you see is for the three-way syringe, never directed towards the orifice. Okay. So if you can see this, these schematic diagrams also. So if you have the barrel of the three-way syringe like this, the air would escape maybe for a mandibular or a maxillary. But whenever you are looking at using a three-way, first and foremost, three-way syringes are not to be used, Faisal. As I said, there is no correct way or wrong way. The three-way syringes are not to be used for drying a tooth, not to be used. Even if you are blowing air, never in and around the vicinity of the tooth which you are drying, never do it like this, where it is directly towards the canal. And for drying the canals, obviously paper points are to be expected to be used. And even if you're looking at drying in and around the vicinity of the tooth, always hold the three-way syringe at an angle, which is not directly towards the tooth, away from the tooth, maybe. Yeah, that is what.
One more question is about the use of paraformaldehyde for the pulp divide light.
Never use it, guys. Never use it. It is going to cause more pain. So previously, the one which I showed you in my presentation was from Septoten. I mean, previously the problem was that they used to say that there was arsenic in it, so that arsenic was actually needed to be avoided. But what we understand is that especially when you're using it for emergency cases where the pulp is extremely inflamed, using it again on an inflamed pulp is going to increase the pain of the patient. So please do not use this. Do not use this. So this is what is it? Kostanov is what your question was. Previously, as I said, we used to have arsenic. These guys say there is no arsenic. So they recommend that after you've done a pulpotomy, put it on this, leave it for 6 to 7 days. When the patient would come back, his pain would be relieved. You can do the second sitting without local anesthesia. Guys, you got to be really lucky. Most of the times you're very, very unlucky. You put this over an inflamed pulp, the patient would come back in 48 hours and he's not going to be very happy, because we've understood over years that this thing just increases the pain, increases the inflammation. Yes. Yes, please.
Next question is about
Yes, Faisal.
Yeah. Time required for the intracanal calcium hydroxide to act.
Yes, 3 to 5 days. It acts immediately within the next 10 to 12 hours you put, but its efficacy as an intracanal medicament is only limited for 3 to 5 days. So if you've given a slurry of intracanal medicament in a canal, and if you say come after 10 days, the intracanal medicament is of no use. Its efficacy is gone after 3 to 5 days. So the efficacy starts immediately, maybe 10 hours, but it only lasts up to 72 hours to 96 hours. So you've got to recall the patient and either obturate or change the dressing. Yes.
Okay, next question is, there are patients who do not want RCT done. In such cases, is it necessary to do access opening only to access opening, or only prescribing medications? Is it enough?
You see, the patient, especially in COVID-19 times, they're just saying that just prescribe us the medication and we'll go back. So if a patient with irreversible pulpitis comes, I've told you, giving him antibiotics is just not going to help him. If he can survive with the analgesics, it is his choice. But my experience is that in irreversible pulpitis, if you have that that triage of questions which says that in spite of taking the painkillers, the pain is coming back after 93 hours, 96 hours. And if the patient is getting up in the night because of the pain and it has been there for 48 to 72 hours, yes, root canal would be necessary. No amount of medication. The only other way is injectables, Dr. Faisal. Maybe the patient can graduate himself to injectables, but that also as an emergency measure. Unless and until you do not open the access opening, you do not do the emergency procedure, the patient's pain is not going to go. The option remains of extraction is always there.
Yeah. Next question is how the photo-activated disinfection, how it works.
How it works? How it works?
Yeah. Yeah.
Okay,
how does the photo-activated disinfection works?
Okay, photoactivated disinfection is another way of disinfection, which it has a specific dye, which is the toluidine blue dye, and that dye has a specific affinity to a particular wavelength of light. If I'm not wrong, it is 606 nanometer light, or maybe 606 nanometer light. So it has a specific light. It has a dye. The dye is usually toluidine blue. When you so what you're supposed to do is you got to take the dye, put it into the canal and agitate that dye inside. The dye gets binded to the bacteria. Once you show the light, which is a specific light of that 606 nanometer, please may be wrong by 10, 15 nanometer. When you show that light, it is a bactericidal method of disinfection. Separate seminar for it.
Yeah.
Webinar.
Yeah. One more question is about the periapical abscess. If you do over instrumentation, does it work?
No. So guys, over instrumentation should not be done. The only thing which is I think the doctor who wanted to ask the question is apical patency. All right. Over instrumentation means going beyond the major apical foramen and doing biomechanical preparation. No, it does not work. It's going to flare up. It's going to come back as a worse case. Guys, the only thing you need to do is that after you have prepared the canal, which I said should be at least 35 size for a posterior tooth, for the irrigants to be there, then take a sterile number small 10 file, sterile, new sterile 10 file, go gently beyond the apex. That is, if you're using an apex locator, go on to the apex mark with that. That is, just go once and come back. That is sufficient. No instrumentation. I hope that, see, Faisal, I think maybe my emails can be shared. If they have any specific questions, which I would require them to explain them more, maybe they would be, I would be benefited if I can pass my message to them better.
Yeah, I'll share your email with them.
Yes, thank you.
Okay.
Thank you.
Do you have to wait for 15 minutes after giving anesthesia for all cases of irreversible pulpitis?
100% by the clock. So you keep a stopwatch. So you give an inferior alveolar nerve block, sit with the patient, wait exactly for 15 minutes, and then only start your endo. And another step is if you have the electric pulp tester, after 15 minutes of having given the block, check with your electric pulp tester on that tooth, then reading, the patient should have no sensation. Then only the anesthesia is good. Anything lesser, a little more is preferable, Dr. Faisal. Lesser would be painful. And always remember, if once the pain starts, the central neural system gets sensitized, the pain persists. So it is better to wait 2 minutes more than 15 minutes by the clock, but lesser is harmful.
Next is regarding the avulsion cases. After reimplantation, after 7 days also, the tooth is mobile. How do you, when do you start the RCT for this patient?
No, so it all depends, Faisal, on whether you are dealing with a mature apex or an immature apex. So if the question is coming from a pediatric dentist, it would be an immature apex. So if in combination, whether it was an immediate reimplantation versus a delayed reimplantation, Faisal, again a separate webinar, but in just short, I would just talk from a mature tooth point of view. If it is a mature tooth, and if it is an immediate reimplantation or a delayed reimplantation, you've got to do the root canal within 7 days. 5 + 2, 7 days. Otherwise, the resorption will start taking. Whether it is mobile or no mobile, obviously the splinting is there for 14 days for an immediate reimplantation of a mature tooth. The similar is for an immature tooth, but if in an immature tooth, if it is an immediate reimplantation, wait and watch for revascularization. Again, I think this doctor can benefit by email share, and maybe I would be in a better position to tell her details of her or him.
Even if there is a space infection associated with tooth, then also should we give a closed dressing?
Yes, never. So yeah, space infection is a, you see guys, if it is an abscess, by opening the axis opening and doing the biomechanical preparation complete, by doing the apical patency, you have drained whatever could be drained. Then you've got to give a closed dressing. If it is a cellulitis, you're really not looking at any drainage for anything to occur. Our evidence, our clinical experience suggests by leaving the tooth open, you're reinfecting or infecting it more, and very, very difficult to control the infection after that. Yes, relieve the occlusion, close the dressing, monitor the patient. So it doesn't mean that is all closed dressings would be successful, just out of my experience. So relieve the occlusion, close the dressing, monitor the patient. If you feel the patient's symptoms are increasing, maybe 6 hours. If you've done it in the morning, you can recall him in the evening. If you did it at 6 o'clock in the morning, make sure the patient is contactable in the early morning. That's the importance of talking to them. So you can reevaluate it, call the patient back, re-access the tooth, irrigate, but close it always, guys. Close it. Yeah, message is clear.
What's your opinion on triple antibiotic paste?
Yeah, triple antibiotic paste is specifically, Faisal, it was to be used when you were using revascularization, and it has started from that end only when we were looking at doing revascularization. As a routine for endodontics, please avoid it. Calcium hydroxide is good enough. And as I said, the whole issues of antibiotics, whether local or systemic, is going to be an antibiotic kind of resistance being developed. So please avoid triple antibiotic paste. And you do realize that the minocycline can cause discoloration well, unless until you're planning a revasc, maybe some indication. Routine endodontics, no, please. Yeah.
Do you recommend, almost same question, do you recommend any agent for application on an inflamed pulp after the emergency access opening?
No, the evidence is very strong. Our experience is very strong. Do the pulpotomy. So there is vital pulp tissue, a sterile cotton. I insist on a sterile cotton, because even if the cotton which is lying on your chair side may not be sterile, specific sterile cotton, put it there. Do not push it against the pulp. The reasons for that is you've got to take the sterile cotton, just ladden it with either distilled water or normal saline, because the dry cotton, if you put it, even those fibers of the dry cotton sometimes tend to increase the inflammation. So take a sterile cotton, ladden it with distilled water, squeeze it, just place it gently over the pulp, pressureless technique. Don't push it against the pulp. Give a temporary, again, don't push the temporary. So the pulp has to be just be there in contact with the cotton, and on top of that, a filling. Pressureless technique. Yeah.
I think I'll share your email with the participants. They'll send the questions to you directly.
Yes.
If they have any more doubts. Okay.
Yeah.
Thank you very much, Ajay Logani, for being with us. Over
Thank you,
to our,
Faisal.
yeah, over to our secretary and president to have the final
Thank
word.
you very much for everybody, please. Thank you, Dr. Joseph.
Hello.
Yes, Dr. Joseph.
Yeah, sir, it is a wonderful presentation.
No, I
Actually,
hope you.
emergency and urgency. Yeah,
Yeah.
we people really in need of such a session now. And the most important thing I can get it from this your talk is the reassurance. Reassurance to the patient. Any emergency treatment they are done, the reassurance of the treatment and the reassurance of the
Yes,
patient
reassurance is
is
something.
very important. So it is happy. Yeah. So thank you very much on behalf of ID Kerala State. I would like to thank sir.
Thank you very much. Thank you.
Thank you, sir.
Thank you very much.
Over to the secretary, Deepu.
Yes, please. Deepu.
Deepu
Yes,
is
Deepu.
not there.
Deepu is there? No, Deepu is
No.
there now. Okay,
No,
no problem, please.
no.
Yeah, maybe,
Okay.
yeah.
Once again, thank you, Ajay, for being with
Yes,
us.
Faisal, thank you very much.
Really enjoyed your talk. It was very
Thank you,
informative.
Faisal.
Very
Now,
informative.
I hope that, yes, Deepu has come and Unni is there. Unni has come. Unni, thank you very much. And sorry, we had 2 or 3 breakdowns, but by good luck, we could come back.
No issues.
Sometimes it goes so bad that you can't come back. At least we could come back every time we were off air. And thank you very much. Thank you. Deepu is there. Yes, Deepu is. Thank you, Deepu, for being there and listening through. Yes, thank you.
Yeah, great class, sir. Thank you so much.
Thank you, Deepu. Take care. Take care, please, everybody. Good day, please. Can we go off air now, please, Faisal?
Yes,
Thank you,
bye-bye.
Faisal.
Bye.
Thank you. Bye. Bye.